Welcome, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital, and I'm also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine. We're really thrilled to welcome you today to our second session in the COVID Community of Practice for Ontario family physicians. This is a joint initiative by the Department of Family and Community Medicine at the University of Toronto and the Ontario College of Family Physicians. In that spirit, I'm going to turn it over to Jennifer Young, who's going to give us a little bit of a welcome. Jennifer, as you know, is the current president of the Ontario College of Family Physicians.
Hi, everybody. It's wonderful to see you here, and I am so delighted to join my colleagues presenting this ideas of changing the way we work in this COVID time. Over the last 2 months, I've just been so improved but not surprised at the adaptability of my family physician colleagues across the province. So thank you for our panelists and for Tara for the idea behind this, and we're so happy that the OCFP can work together to create this community of practice. But before we get started, I do want to acknowledge that we are, the land on which we're hosting this meeting is the traditional territory of many nations. We acknowledge that Ontario is the home to many diverse First Nations, Inuit, and Métis people, and that each of you are joining us from one of those many traditional and treaty properties or territories. We are grateful to be able to come together in this way.
Next slide, Brian. So thank you, Jennifer, for that introduction. I've learned from my colleagues, Janet Smiley and Suzanne Schusch, who I work with, that the land acknowledgement is a wonderful opportunity for us to reflect on injustices done to our Indigenous people, past and present. And I don't know if any of you have seen this article from a couple of weeks ago, but I thought I listened to it was an interview with Dr. Janet Smiley, and it really talked about some of the particular hardships facing Indigenous people. Of course, access to healthcare, crowded housing or inadequate housing, systemic racism and others, and how that affects how their communities are being affected by COVID. So if you haven't had a chance to listen to this podcast, I highly recommend it, and our team will send out a link to the podcast in the chat. Next slide. I think the land acknowledgement is also a time where we can reflect on what we can do about these injustices, and we know that many of our own Indigenous patients sometimes, and people who are not actually who are Indigenous but maybe don't want to self-disclose, or who are struggling to access healthcare because of experiences of racism. Sometimes we need a different opportunity for them to be able to engage. And so our colleagues, Janet Smiley and Suzanne Schusch, have pulled together this hotline specifically for Indigenous people. And so this is something that you can advertise for your patients, a place where they can get help that's culturally safe for them. Next slide. So today we're gathered here for our second in our series of our community practice. Our focus today is really on bringing together people to talk about how they've not just changed practice, but also supported family doctors in their community. Next slide. When we envisioned this community of practice, we envisioned a place where family doctors could come together to learn and share from each other, where we could really actually share some really practical tools with each other, where we could connect with each other so that, if we did have questions that were unanswered, we could have someone where we could maybe get some answer from. I just want to also put out there that this is obviously a challenging time in terms of us practicing in a lot of uncertainty. Today there will be a lot of questions, and we're going to do our best to answer them. Some of the answers just may be our own opinion or sharing of what we're doing, and some, though, we also will have people who hopefully will be able to provide some insight into where things are at, for example, at a government or provincial perspective. Next slide. So this program has been put together, as I mentioned, from the Ontario College and the Department of Family and Community Medicine. Next slide. And I just want to acknowledge our fantastic planning committee, Trish O'Brien, Leanne Clark, Suzanne Taylor, Mina Viscardi-Johnson, as well as some people behind the scenes, Leanne Butler and Marissa Schwartz. And our planning committee has had all control on the choice of topics and who we invite and the kind of questions we frame. Next slide. Thank you for all of those people who joined us last time. We had a fantastic first session, as you may remember, with David Kaplan, Mercedes Rodriguez, and Kim McIntosh. And we have now posted the recording of last week's, sorry, it was 2 weeks ago of our last session. We've posted it at this website. And so I'll just ask my colleagues on the chat if they can send out that link, just so you can easily click on it and see it if you like. Along with the recording, we have a curated question and answer. So we got some questions and answers that we answered during the session, but actually there were a number that were asked afterwards. So beforehand that we actually didn't get to during the session. And so we've taken the time to put together a response there. So some of the kinds of questions we were asked are, should we be continuing ACE and ARBs? What do we do for PrEP? Should we be doing the blood work or just renewing the medication? Are people giving Pneumovax vaccines still for adults? So check that website out and you'll see some answers that we've pulled together. Next slide. So today I'm really excited to welcome our panelists, Dr. Arieg Badawi, Dr. Nadine Laraya, and Dr. Daniel Pepe. The three of them bring different perspectives from different regions of Ontario, Milton, West Toronto, and London. Last time around, all of the physicians that we had on actually worked in family health teams. And this time around, we're featuring physicians from other practice models. So Dr. Arieg from a FIG model, and Dr. Nadine Laraya and Dr. Daniel Pepe from phone models. Next slide. We're also delighted to have as panelists Dr. Jennifer Young and Dr. David Kaplan. So Dr. Jennifer Young and David Kaplan will be are going to be available for the question and answers. Last time around, you guys had lots of great questions, and a lot of you guys have sent in questions in advance of our talk today, and we hope to be able to answer some of them. We won't get to all 50+ questions, but we are planning future community of practice sessions where we hope we will get to some of them. So for example, there are lots of questions on virtual care. We might get to some of them today, but I'm sure a future session will be focused more on virtual care. Next slide. So without further ado, I'm going to turn it over to each of the panelists to introduce themselves and speak to their own disclosure. Arieg, do you want to go first?
Emily Dock in Milton. I don't have any conflicts to declare except for maybe I'm going to talk about Penny Appeal, which is a non-for-profit organization that we've been working with, but that's about it. And it's nice to meet you guys.
Nadine?
Okay, hi, thanks so much for having me here today. My name is Nadine Laraya, and I'm from Toronto, the Toronto area. I don't have any disclosures today to disclose or conflicts to disclose. Happy to be here. Thanks.
Daniel.
Hey, good morning, guys. I'm Dan Pepe. I'm a family physician from here in London, Ontario. I don't have any conflicts to disclose, and I'm happy to be here to join the panel.
Thank you. Next slide. So as I mentioned, I'm Dr. Tara Kiran. I am a clinician. I see patients in the office, but I also spend a lot of time doing research. And so I do have a number of grants and salary supports to disclose, which you can see there. Almost all of them are from non-for-profit agencies, except for Gilead Sciences, where I do have a grant to support a project related to curing hepatitis C. David, are you on the line? David may be late in joining us. I'm going to turn it to Jennifer.
And as with the former speakers, I'm Dr. Jennifer Young. I'm a community family physician in Collingwood. I'm the president right now of the Ontario College of Family Physicians, and I have no relationships, financial sponsors. No conflicts to declare.
Next slide. So you're obviously joined by us as panelists, and what we're not able to do is have each of you introduce yourselves, but I see that we have 84 participants on the line right now, which is fantastic. And this is just a snapshot of where you guys are from. So when you registered, we asked you what city you practice in. I think many people, of course, are from the GTA, but not everyone. We've got people from all across Ontario, and so welcome. It's wonderful to have you here. And so part of what makes this a community of practice is that we want this to be interactive. We want to hear from you. We want to hear your questions. And please also feel free to share your experiences and your suggestions as answers to questions that others asked. Next slide. So I'm just going to go over how people can participate. You can use the Q&A button, which is a button that people actually may not be as familiar with. It's not present on most Zoom meetings that you may have attended. So if you go to the Q&A button at the very bottom and you press it, you'll see that there is a place where you can post questions, and then we as panelists can answer those questions, and we may answer them in type or we may speak to them verbally. If you have questions, I would really encourage you to put it into the Q&A. It's just easier for us as panelists to keep track of them that way. We, of course, and then if somebody else asks a question that you like, just press the thumbs up, and that question will get voted nearer to the top, so we know to prioritize it. There is also, of course, a chat function that almost everyone should be familiar with, and the chat function helps I think each of you to interact with each other. So if you wanted to say hi to somebody, if you wanted to answer a question, you won't be able to answer it on the Q&A, but if you had something that you wanted to share with somebody based on what's being said, please put it on the chat. Last time around, I think there were a lot of fantastic suggestions that came from the chat. So those are the two ways you can participate: Q&A for questions and chat just for general comments. Next slide, Brian. So without further ado, I'd like to turn it over to our panelists. We're gonna start with Dr. Arieg Badawi. Dr. Badawi, you work in a family health group, and you also have a leadership role in your community as the lead of your North Halton, Ontario Health Team, which I think is in development. Can you start by telling us a little bit about the unique challenges you and other FIG physicians have faced and how you have supported one another to try and meet these challenges?
Sure. So thank you so much, Tara. So I'm a FIG doctor. Milton is a lovely community. The North Halton, Ontario Health Team, which is in development, was actually, it kind of came at the right moment, because what happened was, just to kind of give people a background, we were completely, if you've ever worked in the community, fee-for-service docs and FIG docs, everyone's working in their own little corner. Nobody talks to anyone. So what happened when the North Halton, Ontario Health Team initiative came along? We basically connected together. It was completely grassroots, so we kind of built some relationships together, and then we basically designed a WhatsApp group. This WhatsApp group became kind of our connection to each other. It's real information, real time. We can basically send out messages and meetings, so it was very handy. When the COVID-19 pandemic happened, all of us were kind of shocked. Just talking from a FIG perspective, we've adjusted our practices right away with virtual and phone. We will not get paid for these K codes until probably maybe in the summer. We had to lay off people that who are working with us. Our income dropped drastically. In addition to that, there was a lot of information that was going around. Like different screening protocols. So basically it was confusing. So what we did is we took 2 weeks to just calm down. And then we looked at who is going to be distilling the best information. So best information is distilled through the OMA. It's actionable, it's quick. These are the people that we're going to get the information from. We listen to the Central Table, which is the Central West Lynn. They're awesome. Like, we do like our leadership a lot. And so, but we kind of I remember the first meeting, them saying, we're going to get 6 million PPEs. And, you know, at that point, the hospitals had no PPEs, or maybe they were running out of PPEs. We had long-term retirement homes that were basically not really coming into the picture yet, but we are community docs. So we could basically see there was going to be a gap there. So we identified, what's our problem? PPEs. Are we going to get any PPEs? No, we're not. You know, people can promise, or maybe next year it might come. So what we did was a group of us got together. Information was there. PPE was a problem. And so we basically just donated, a couple of us, like money. And we said, okay, we're going to make sure that we have a secure supply chain for PPEs. One of our colleagues, her cousin is in China. They're Canadian Chinese, and this is the beauty about Canada, is that you're gonna find a Canadian anywhere in the world, right? And so we were able to kind of secure that link where we know that the supplies coming from China are authentic and they're international standards and certified. The issue was, how are we gonna get that kind of the supplies into Canada? Because then you're gonna have to pay a lot of money if you're not a non-for-profit. So we paired up with a non-for-profit organization here. And so that way we can actually bring the supplies in. So we bought the supplies, there weren't a lot, and we've divided it between all of us because I wanted to make sure my colleagues knew the quality of the stuff that was coming in. And now we've actually fixed the problem for PPEs, where everybody is worried. We've actually now have enough amount. You can basically order through this non-for-profit organization. You're gonna get the charity discount, and at the same time, we all kind of order together, but individually, if that makes any sense. So they take care of the order and then they ship it to your clinic. That kind of fixed our PPE issue. The income issue I will talk about later if we have time, but I think that, because I know a lot of people are kind of concerned about the PPEs, so I'm gonna just leave it at that, and yeah, that would be the first part.
Thank you, Arieg. Before we go actually to another panelist, maybe I know Jennifer or David, would either of you like to speak to the issue of PPE?
David, I think you've been involved most specifically with the program, I know, and from the OCFP standpoint, we've been sending a letter to the ministry. We've been lobbying, advocating, I think, consistently since the beginning of this, fully aware that that the priorities of long-term care and hospital and have trumped those of community family physicians. But we have really raised the point that community family physicians up to now have not had a centralized location to which to go for ordering their PPE, and that this is a system fault that our present epidemic has shown. We are lobbying for that to change. David, you've got some more insights into the specific initiatives to get PPE.
Sorry, all I can add is the government has been trying to secure an additional tranche of PPE that's going to be released both to primary care as well as home care. But we have to remember that all this PPE, the strategy the government has right now, is a pandemic strategy. It's not really meant to replace our existing purchasing ability in primary care and elsewhere in the system. It's really meant to figure out what are we going to do 2 weeks from now and in 4 weeks from now, not what's going to happen in 6 weeks from now or 8 weeks from now. And so we're coming up with a short-term strategy in different regions across the province, because obviously the geography pays a difference in how to get that PPE out. But stay tuned. I think there'll be something around PPE in the next 10 days for practices that are critical supply and need to stay open. If you are really a critical supply, there are ways through your local regional leads to get access to emergency supply. If you don't know who those people are, if they haven't been able to get that email out, you can email me directly and I'll make sure it gets, you get to the right person. It's dkaplan@hqontario.ca, Kaplan's with a K. I'll put it in the chat.
And I think just this is a good opportunity this question comes up all the time. What is the essential PPE? Shall I answer that right now?
Yes,
Okay,
please
yeah.
go ahead, Jennifer.
So for COVID suspects, the gown is necessary. For non-COVID suspects, mask and eye protection, excellent hand hygiene before and after. Maximize distance for the longest time during your interactions, minimize the close contact that you have your patients sit on one place in your exam room, keep their hands to themselves. We have our patients wearing masks, be they bandanas, but preferably it's been interesting, the variety of masks that my patients have come in with. And then conservation, reusing of your masks. I must say I've been using the same mask for the last week because we have so few patients actually coming into the office. I would say about 10 to 25% of my patients are in person. And I remove the mask and put it in a safe place, and then reapply it again. Hand hygiene before and after putting a mask on. If you're having the procedures that are if you're doing a procedure, for example, in the office where you are close to somebody, if you're removing a lump or a bump, or you're fixing a laceration, if you do that in your office, then wearing a gown you'll have longer contact with the person, and so wearing a gown would be suggested. But for the in our green departments, in our emergency room, for example, we are not wearing gowns. We're just wearing masks and eye protection and hand hygiene before and after.
So I see that there are a few questions that have come up, and I just wanted to address a couple, and then maybe also ask Arieg if she could comment on a couple. Lee Donahue mentioned that there's a list of PPE leads in each region, and I just wanted to mention that David Kaplan did share that list last webinar, and we have posted it on the website. So that link that we circulated earlier on in the session, if you go to the DFCM webpage and the COVID Community of Practice and last session, the list of the regional leads is there. Jenny Clement comments, the issue with PPE is that if we aren't seeing anyone in the office, then our supplies last a long time, but we'd like to move to 99% from mostly virtual visits to actual patient visits. And to do this, we require a steady stream of PPE, and the questionnaires don't capture this. So Jenny also did ask, is this PPE initiative something that other MDs can access? So I think that was a question to you, Arieg. And then Andrea Stern, Arieg asked, how did you ensure that the PPE met current standards? There has been some reports that some PPE, especially masks, did not meet standards. Arieg, you're on mute, sorry.
So I'm gonna have to ask Brian to, yeah, can you hear me now?
Yeah.
Perfect. So Jenny, that's a very good question, and I agree with you 100%. I think that relying on donations is not something I do think is sustainable. And even when they talk about critical supply, what does that mean? My understanding, and Dr. Kaplan can actually go more into detail, but I think they've selected 13 clinics that was kind of last Friday that will be getting that. So just to understand that that's a system level, we are grassroots, so we need to sustain and maintain our clinics, right? And so yes, I agree with you, order your own. Remember that there's always a supply demand issue that we have to keep in mind. The demand's always going to be higher. So just don't rely on donations. Do not rely on, if it comes from the government, we're happy. If it doesn't, you run your own clinic. Send me an email after, and I will get you connected with the PPE supplies that you need. Now, the second question, I believe, was it James who asked about how do I know if it's credible? So we did a lot of vetting. We have international certificates that are there. So when you get your PPEs, you'll be able to kind of look at all of the specifications. Now, I'll give you an example. So Friday, there's a community drive that has been done in place by the OMSA. So this is the Ontario Medical Student Association. And I looked at a number of face masks that came and a lot of the N95s, and I returned all of them because they do not meet the certifications that we like. And so it's very simple to do, and you will be able to see the certificate there when you get your product. Okay. Does that kind of clarify it?
Thanks, Arieg. So I know there's a few more questions around PPE, and I hope that we'll be able to get to them. I think Jennifer is also answering some of them into this chat. People have been asking for the link to the PPE leads, and we reposted that in the chat. So without further ado, I'm going to just turn it over to our next speaker, Nadine Laraya. So Dr. Laraya, you work in a FO, and you have a unique role as the Community Family Medicine Liaison with St. Joseph's Healthcare. Just last week, you were recognized as a healthcare hero by CBC Toronto. Congratulations. And I think there was just like this really sweet video from one of your colleagues that described the great work that you've been doing, providing information to them and being really appreciative of that information. Maybe you could tell us a little bit about how your own practice has had to adapt to COVID during this time, and then how you in your role have supported other doctors in the community to adapt as well.
Okay, great. Well, thank you so much, Tara, for inviting me to speak today. As you mentioned, my name is Nadine Laraya. I'm a family physician in West Toronto. I work with the Metro West FO, and I also hold a role with St. Joseph's Health Centre, the Community Family Medicine Liaison, which is a relatively new position in the last couple of years. I'm also involved in our local Ontario Health Team development plan, and I'm currently the COVID community response lead for St. Joe's, which includes management of the COVID assessment center. So in terms of my own practice, I work in a group practice as part of a larger FO, and we've had to make a lot of adjustments to our clinical work, probably similarly to what others have had to do. We've made the move from in-person to virtual and phone appointments, and we've experienced similarly to other practices, a reduction in volume and a bit of a gap in terms of the patients who we're seeing for our virtual visits versus those who are not seeking care at all. So it's a bit of a concern as to who we're missing. In terms of the physical layout of our practice, we have had to address the PPE issues. So making the appropriate PPE available for all of our staff and making sure we have proper infection strategies in place. So that's required a lot more work every day by our support staff and by our doctors as well. We've had to make changes to our clinic flow so that if we are going to do in-person assessments, we batch them so it's as efficient as possible and as minimizes the use of PPE. So right now we're seeing what are deemed as essential visits 3 mornings per week. And by putting all those in place, we're in a very fortunate place where we haven't had to do any staff layoffs, and that's it's a function of being in a FO model, which I recognize is it's a big point of contention right now because there's so many different models of care out there, and there is quite a difference between what the fee-for-service models are experiencing versus what the capitated model are experiencing, and that's certainly not lost on me. Oh, that me? Oh, okay. In terms of the other role that I hold, so I've been the community liaison at St. Joe's for about 1.5 years at this point, and it's been a communications role and an opportunity to bring together a group of about 200 physicians in West Toronto. We serve a population of about 500,000, and in that mix of physicians, about 50% are capitated and 50% are fee-for-service. My job over the last 1.5 years or so has been to get them connected with one another and connected with St. Joe's. And COVID has been an opportunity to really strengthen that because there has been so much information to flow back and forth. What I've been doing is communicating regularly with relevant and curated information, at least a couple of times a week via email, and also inviting the group to come together by Zoom about every 3 weeks to bring together hospital experts and the group to ask questions so that everyone has a good sense of what's happening at the local level, both at St. Joe's and within local practices. And I've positioned myself as a go-to person. So most know that they're able to email me or even text or call me with questions that they just can't get answers to through the usual resources. So as a result, our community has been so regularly informed about what's been happening at the hospital. So everything from infection statistics to the ICU and ED use, what our visitor policies are, what our new initiatives are. For example, going forward, we'll be having new initiatives with long-term care support, how they can access certain specialist services like palliative care. And they've also learned about opportunities to redeploy clinically in places like the CAC, in the emergency department for supportive role, and for a virtual follow-up clinic for any patients who don't have family doctors who are accessible at this point. The hospital has had an opportunity to gain a new source of HR and newly connected physicians because they've all been given credentials. And the hospital has had an opportunity to become aware of what some of the issues are in the community. For example, the different issues that the different practice models are experiencing. We've been very vocal about our lack of PPE. There have been, issues around clinic closures and how to fill gaps with patients who don't have options to be seen. And together, our next stage is going to be to move forward as a group to plan for the quote clinical service recovery stage of COVID, which is going to last probably months into the next couple of years. So all very exciting things. For me, that's it's been a bit of a shift in practice, and it's been a shift in workflow and workload. The last thing I'm happy to speak to, but I think I'll probably leave it at this for now, is the shift in wellness initiatives and resilience strategies. Ones that I've been promoting for our community, and as well as new resilience and wellness practices I've put in place to myself. So I'm happy to speak to that if anybody's interested, but I think I will stop there. So thank you so much.
Thanks, Nadine. It's wonderful. So thanks to everyone who's continuing to ask some questions. There have been some questions just about the logistics of today and the Mainpro credits, and Susan Taylor has put that up on the chat. I think people can't find the information on the regional lead, so Trish O'Brien has kind of put that there. There are also some questions about asymptomatic patients and PPE, and Jennifer has posted a nice response there that masks and eye protection, hand hygiene and distancing for all patients, reducing time of close contact mitigates asymptomatic shedding. So thank you, Jennifer. So thanks, Nadine. I'm going to turn it over to our next speaker, Daniel Pepe. So Dr. Pepe, you work in a FO in London and also have a leadership role related to digital health in your region. How have you helped your colleagues quickly ramp up their ability to provide virtual care? It's certainly something we're getting lots of questions about from participants who are on the line today. What guidance might you have for folks on the call?
Yeah, so thanks so much, Tara, and to the other panelists. It's kind of nice to hear what's happening across the province and the region. From a digital health standpoint, I've only been in practice about 1.5 years, so I'm still in the building phase of my practice. So we're still seeing new meet and greets. I share practice with my wife, and we kind of tag team things throughout the week. And so about 4 months ago, I took on a role as the primary care digital co-chair for our entire health team pre-COVID, when everything was getting set up and you could see the kind of old infrastructure. Here's a hospital, here's the non-hospital sector, here are all these other groups that are trying to work together to care collaboratively for patients. And we had done some early work in terms of asynchronous messaging and secure messaging between docs and patients. And that model has really been accelerated. I said to somebody the other day, COVID is like this great accelerator, just poured gasoline on top of a lot of these good initiatives. And so although there are things that strain the system in terms of the funding models and the PPE and the clinical risks of docs, it's really provided, I think, an opportunity for us to explore what could a digital healthcare system look like, and what could it help us do, and what could it free up our time to do. And so in terms of helping out colleagues just around the office, it's explaining, here's virtual healthcare, here's how you consent your patients. This is a generic consent that you can actually use to give to your patients when you're seeing them for the first time. Fortunately, over the last year, what we've actually done is we've onboarded patients as part of our welcome packages. We've actually sent out an email consent. So you can use things like Ocean or like Help Myself or other tools to actually gain that email consent so that you can start to communicate electronically with patients. The other thing I think before I go down the digital rabbit hole is a phone is virtual care. I think it's always this assumption that you must have all this technology and you need the latest computer and your patient needs high-speed internet access. But I think just going down to basics, if you have a trusting and sustained relationship with your patients, you can actually do a lot of care over the phone. What I found is that these little kind of micro interactions with patients, I'll call someone for 5 or 10 minutes and say, hey, how's it going? How's your heart failure? What's happening with your legs? Are they swollen? Are you short of breath? And just knowing someone and having that kind of deep personal knowledge of them or their family allows you to manage things very well over the phone. And so you don't need to spend necessarily 20 minutes in an office talking to someone, but you can do daily touch points. And with those daily touch points, you can actually collect information and data to help guide your clinical decision making. And so that shift in my practice and in my colleagues' practice has been really interesting because we found a lot of the kind of chronic, more complex comorbid disease actually becomes a little bit easier to manage because when you're not in the office being pulled in 50 directions and you're sitting in your home office, you actually have time to think and reflect. And if you're talking to someone multiple times a week, you can really gain a sense as to where the trajectory of their care is. On the collaborative side of things, I think seeing a lot of specialists now come on to things like e-consult has been great because now we have access to all of these specialists that were kind of hesitant to get onto e-consult, and now it's more of a, okay, I need to get onto e-consult. So now you have access to a cadre of specialists. So when you have a question, you can say, hey, this is something I have a question about. Can you help me? Does this patient need metolazone for their, chronic kidney disease or heart failure, or should I go a different route? What would you suggest? And at the same time, I think it also gives us the opportunity to talk to other specialists or other healthcare providers like pharmacists and start to build those relationships. So that's been a nice side benefit, I think, of COVID is we've learned and explored these other things that we didn't necessarily do when we were in our office going room to room to room to room. We're starting to actually build the community practice both within primary care, but I think also between other healthcare sectors. And so those are some of the things that we're working on with my kind of leadership hat on. I'm the Southwest Digital Pandemic Lead. And so what we've been trying to do from that standpoint is come up with an action plan that we can distribute across the Southwest, which is kind of London, St. Thomas, Oxford, Grey Pierce, and Kiran Perth, it's a mix of urban, regional, and rural environments to try and figure out how can we use digital health solutions to actually create equity across that system, and how can we give patients across different care settings access. Because we do have docs who work in fee-for-service, FIG, and full models, and how can we use technology to kind of share information across the providers, but then also distribute resources to our patients. So even if I'm in a FO and I have access to something, how can I work with my FIG or fee-for-service colleagues to share those resources? So it's been really interesting, to be honest, and it kind of changes on an hourly basis in terms of what's out there, what's working, what's not working. So I would say, if anything, COVID has really given us an opportunity to look at how we practice and see if there's a way where we could practice more efficiently or in a way that allows us to provide better and more continuous care for our patients. So.
Thanks, Danielle. I mean, there's a question that just came up right now about, can you give me more detail on how to do or use e-consult?
Yeah, so for sure, if you have not signed up for e-consult, I'll dig up the link and we should put it probably either in the chat or answering the Q&A. But what it is it gives you an opportunity to say, I have a clinical problem, and let's say someone's diabetes is getting a little bit out of control, and you're asking yourself, do I need to put them on insulin, or is there another intermediary step? You can actually take that history of your patient, put it in a PDF, maybe attach a couple of clinical notes and some blood work, so you can tell the story of that patient to the specialist, and they can look at that information and then, based on the best evidence, give you an answer. And if you haven't provided a piece of information, they have the opportunity to ask more information or clarify. And say, could you tell me about this? Or did you order this test? And if you didn't, you actually have the opportunity to order that test and then re-upload the information. One thing that I've started to do, probably because I'm a little bit of a younger family physician, and I don't know everything that there is to know, is I will send a message to a specialist and say, here's my clinical problem. I think this person has worsening chronic kidney disease. What are the investigations that you would want? So that way I can tee them up and have all the information there so that if the patient does need to be seen in clinic or seen by a specialist, we've done the workup and we've done it appropriately. Then I take that information and I'll put it in a stamp in my EMR to say, okay, next time I run into that problem, here's the workup. And so you kind of learn as you go, but that's how I use eConsult. Thanks, Dave.
Thanks. Thanks. Yeah, so please do, Daniel, if you could add the link to the Q&A or the chat, that would be fantastic. Oh, I think David Kaplan.
Yeah, he's on it already. That's great.
Alan Brill has put in a link there for KidneyWise in case you have any questions about whether someone does have worsening chronic kidney disease and what you need to do for that. You know, we've also gotten some other questions in the pre-session about virtual care. So, you know, what's the best virtual system for face-to-face online that is free, secure, and won't record data? I'll say that I have also been using OTN video for that, and I find it actually works quite well. It's pretty easy to use. I don't know, Daniel, if you have any other recommendations. I know our hospital also, I will say, has endorsed, there's a PHIPAA compliant version of Zoom out there as well, and so they've officially endorsed that, but I do find OTN to be, it's obviously free and easy to use. Do you have anything else that you could recommend around that, Daniel?
Yeah, so I'll give you my kind of general advice around technology and virtual care. It's not about the technology, it's about the problem that you're trying to solve. So the technology kind of becomes secondary, and you have to ask yourself, what am I trying to do? Am I trying to get a specialist opinion? Am I trying to communicate with the patient's family? Am I trying to collaborate across providers? Because I think what will happen is we'll all get advised that there's 700 different great solutions and they're all PHIPAA compliant, they're all wonderful, and they all have 6-month free trials, but you really have to ask yourself, what is the problem you're trying to solve? And if you can answer that and figure that piece out, the technology will follow. So yeah, Dave's put lots of good stuff in terms of eConsult integration in the question box. There's Doxy.me, there's Zoom, there is OTN, there's things like React, there's also tools like Hypercare. And what's happening is every digital tool is now building in the ability to send pictures, to text, to do secure messaging, and to do video. So I think by the end of this pandemic or in the next 6 months, they're all gonna have that functionality. So you really have to ask yourself what's best for my experience and what's best for my patient's experience. Because I think the risk that we run is every clinic in every sector has a different tool. And then patients end up with that portalitis that they've had before with 50 different access points to get care. So I think it's our job as family docs to say what's going to integrate them and what will give them one click, one point of access to get in. So I'll leave it at that.
Thank you, Daniel. So some really great discussion on the chat. I think what you're saying is resonating with a lot of people. And as you said, David Kaplan has added a lot of great resources there. I know another question that had come up earlier was what are people doing with forms like PHQ-9s during phone visits? I myself, for example, use Ocean, so our practice has Ocean, and that enables me to, while I'm on the phone with someone, I can email, secure message them using Ocean, the form that they can then fill out, and it populates into our EMR, so feel very lucky to have that tool. So Barbara asked a question here. We were previously booking most patients for 15 minutes and finding harder to predict the time we need. Is this helpful if the doctor checks the schedule of time and lots more time if necessary, but it's sort of hard to keep that up? So how are others scheduling visits and advising their receptionists? You can't get behind on your next patient if you're waiting for their phone call. I don't know, Nadine, you mentioned that you might be able to speak to that. Maybe I'll turn it to you.
I've been finding that to be quite challenging, and I've been looking at my schedule over the past few days and finding that I've had a lot of virtual visits booked back to back, and there are other little micro tasks involved with that, which I'm finding take up a lot of time, including populating the chart with the right templates and getting the appropriate information in, and then making sure the video links are out there. They're not difficult, and I'm still kind of working out my processes there, but I think what I'm going to start doing, and I've seen other people in my clinic do this as well, is start to space out a little bit in between, so that instead of having 5 back-to-back visits so that you're behind by 20 minutes by the end of it all, is to space them out and then fill in the gaps as needed. So you're kind of filling in every other every other slot, and then kind of filling in the middle as you go. And then trying as much as possible the night before or first thing in the morning to do all those little tasks in batch. So send it all the video links in one sitting, and then populate all of the progress notes with all the information you're going to need and the templates you're going to need in one sitting, so that everything is ready to go. Those are the sorts of things you learn along the way, and I found have started to shave the seconds and the minutes off so that I don't run behind. But it has been trial and error for sure.
Great. Thanks, Nadine. Actually, so another panelist mentioned we've been giving patients a range of times for phone calls, not an exact time. For example, you'll get a call from 8 to 12 tomorrow. Then there's not the same pressure to get to the phone calls at the same time. So different strategies, and please feel free to share your strategies on the chat. I think that's helpful for everyone. We did get some pre-session questions that I'm going to also turn to now, and I'm going to ask Brian. Brian, are you able to go back to our slide deck where we left off? So if we go to the next slide, really speaks to the Wellchild visit. We did get some questions about the Wellchild visit in advance of the session today. People asking, are we supposed to see healthy babies in clinic? If so, are we cleaning the rooms rigorously after the family is left? What's the recommendations for Wellchild care immunizations? So, I mean, I wanted to highlight here, if you haven't seen it already, and my colleagues can send out that link on the slide onto the chat so everyone can access it. But I wanted to highlight this great guidance that was produced actually by my colleague Tally Bogler. And it really talks about kind of a modified Wellchild visit schedule, what you can do in person and what you can do virtually. Bottom line is that we should continue to be giving the Wellchild immunizations. And we can, and obviously those need to be done in person. When there's a visit not related to immunizations, that can be done virtually. I know some of us in our clinic, for example, are trying to minimize the time in person by, for example, speaking with the patient and parent the day before and doing much of the work virtually the day before. And so then the child is really just coming for the immunization and the weight, height, head circumference measurements, so that we minimize the amount of time in clinic. So if you haven't seen this, this is a great resource. Next slide, Brian. People did ask about, so the question was, if we see them, do we need to clean the room rigorously after the family has left? And I just wanted to highlight this great in-person visit guidance produced by the OCFP. So if you haven't seen it already, please check out that website. And it's a short document full of really important good tips. Yes, they do recommend that even after you're seeing someone who's asymptomatic, that you wipe down the room or the surfaces that they were on, and so you can see that there. Next slide. People also asked about, can we move forward with screening procedures during COVID-19? And so I just wanted to post here what was the advice given by Cancer Care Ontario, that we are suspending all non-essential health services, and this includes screening. Screening is a non-essential health service. And so the recommendation is that we do not continue with screening at this time. Now, people have asked, when will we restart screening? How are we going to catch up with it? Now, those are really good questions, and I obviously don't have the answer to that. I can imagine that we're going to need to, once we do restart, prioritize probably certain populations. We might need to, we know that there's certain people who are less likely to come in, and we may want to prioritize having them come in. We may want to be creative and designated preventive care days where people can come in and get everything done at the same time. For some of us who are remunerated better for virtual care, perhaps we do send the fit kits and order the mammograms more virtually so we can be more efficient about it. So I think there are going to be some strategies that we can employ, but of course I think that's a great question that we have yet to fully answer. Okay, so I see in terms of the question and answers, I don't see a lot more. I see there's been a couple. So Alan has said, our FIT has set up well baby clinics 2 half days a week one NP and one nurse run it. It makes scheduling easier, no acute care patients in at that time. So thanks, Alan, for that tip. Alan, I know you also asked a question about PPE drives. Are they only giving supply to docs with less than 5 days supply left? I don't know the answer to that question. I don't know, Jennifer or David or Arieg, whether you know the answer to that question.
Oh, okay.
Arieg, yes, go ahead.
Okay. So I did read that was the email that came out. Having said that, again, I think David Kaplan would be the best person to speak about this, because I do know they have an algorithm going into how they're choosing who gets the PPE. Again, I will stress the fact that PPE drives also limited, just to kind of keep that in mind. Yeah, but I'm gonna just hand it off to David. Maybe he'll be the best person to answer that question.
I was going to answer it via the chat box, but basically, again, these are people that have like critical loss of PPE, like unable to keep their office open in the next 7 days. You know, the government is, again, like for every area of the system, hospitals, home care, like it is pandemic, the next 2 weeks. It is not the long-term vision of how we support ourselves in September and October. I think one of the things that we should be doing as family doctors is actually placing orders with our existing distributors like MediMart, because they need to know how much they need on back order to meet those orders. I think a lot of doctors have not done that. They've been told, oh, we're not shipping to you, but they are still taking orders. And I think it's really important that people start placing orders with their existing suppliers, so that when those shipments come in, they can actually fulfill those orders in the fall or whenever.
So a couple more comments coming in, and I apologize that I'm actually having technical issues on my end, so sometimes I'm missing some of the comments if they are going by my screen too fast. For some reason, some of my screen is frozen. But I just wanted to call out a couple of things. Lee, you've asked a couple of times, you know, is there a place where we can actually share things like a Google Drive? You have some stamps that you're open to sharing with others, so thank you. So we're going to take that, our planning team will take that back, and certainly at our next COP, which will be 2 weeks from now, we can discuss kind of where we're at with that, and can reach out to you in the meantime. I think another panel participant, Rena Iapan-John, mentions that, you know, not all patients have access to video visits, and that is an equity issue. And I think, you know, I'm hoping that a future community of practice that we have will focus a little bit on some of the equity issues that we're seeing. Arieg, were you wanting to say something? Yeah, so I think Arieg, you'll need to unmute yourself, or Brian can unmute you. There we go.
Sorry, so thank you. This is just building on the last comment. Patients who do not have access to computers, if they have an iPhone, you can actually do FaceTime. Yes, it's not secure. If you go into Ontario MD website, they will have a link where you basically can talk the person through virtual consent. I do find the FaceTime technology it's easy to use. It's accessible by a lot of people. It's not like trying to set your computer for certain things. So that could be a kind of a small loophole that you can use for people who don't have computers or laptops. Everyone has, well, most people have like iPhones at least, right? So something I've used.
Thanks, Arieg. Maybe what I'll do is, so there's some really great chats on the discussion, I think, about, and I can't keep up with them fully because they're going by fast, but you can scroll down to read about whether you're seeing people with symptoms or not symptoms, splitting your office. So some really great tips there. And I'm gonna actually go to the next slide that we have there, Brian, if you can put the slides back up. And maybe I'll end with one last question, and I'll put this one to Nadine. Nadine, I think you were talking to me about this graphic that I think a lot of us have seen, how, you know, that first, there's these waves of the pandemic, and the first one really is the one we've been focusing on, the immediate mortality and morbidity, and the hospitals being prepared for that. But then, you know, as we move forward, I think as family doctors, many of us are concerned with the second, but particularly the third and fourth wave, the uninterrupted care the impact on chronic conditions, and that might become more a focus of a future COP, but then also the mental health and anxiety. And Nadine, I know you've been thinking about personal wellness, and so I wonder if you could just reflect for a couple of minutes on your reflections on wellness.
Mm-hmm. So I have been seeing a shift in my practice from people being concerned about the symptoms of COVID to now suffering the various consequences because of disruptions to their life, to their income, to their work, their family. Everyone is experiencing this in a very, very different way. So from a clinician perspective, I think we all need to be very, very aware that this wave is going to be big and it's going to be significant, and we are probably going to be the first people that most will turn to with vast problems that we may not be able to solve. So as we move forward in educating ourselves about what to do about the world post-COVID, part of this I hope is going to include some training and some CME around how to address these issues as they come up, because we are in a position to be receiving a lot of very, very worried, very very affected patients, and you can think of all sorts of different scenarios that people are going to be suffering with. So that's the clinician side. On the provider side, or on the physician side, there are consequences to how we've been adapting to this. So whether you're dealing with your own changes in workflow, or loss of income, or the changes in dynamics of your family life through self-isolation and children being at home, we have to recognize as physicians, we are in this for the long run as well. And we are, as most people have said, running a marathon. It's important to know how to keep ourselves resilient so that we can get through this long period, which is also going to have within it numerous sprints. So there have been a lot of great webinars and resources on how to maintain physician wellness. A lot of it is pretty basic around maintaining routines of sleep, hygiene, and nutrition, and basic exercise. I want to highlight a couple of really interesting things that have come up for maintaining wellness in the moment that have helped get through some difficult days. First is, we have had access to what are called 1-minute meditations, which are meditation audio files that can be used while you're washing your hands or donning PPE or doffing PPE. The practice literally takes a minute or less and is done at the same time as you would be doing something essential anyway. And they've been really, really helpful. I wouldn't have thought to use this before, but these are great little files, and I'd be happy to share those. The other thing that has been an interesting way of managing some of the stress around COVID has been to kind of find the curiosity and the joy in it again. And a couple of things I've done is I've volunteered in my kids' online classes, and I've given presentations about COVID to younger people. And just, it's a reminder that there are people who are curious out there and who appreciate learning the basics, and who are really appreciate the impact that you're making and ask great questions. And it does, give sort of a new energy to get through the rest of the day and the week. So look for little things like that to help boost you, because obviously we're not able to turn to our usual strategies, whether they be holidays or gatherings or trips to the gym. So it's about being creative. But wellness is obviously a whole other session as well.
Thanks, Nadine. I think, can you send the link out to the chat group, the 1-minute meditations? And people really appreciated that tip. Brian, why don't we move to the next slide? And as we're at the next slide, I'll just summarize a few comments that are coming in. I think there have been some great back and forth about the video visits. People did mention that you can use OTN on your phone, so somebody doesn't need to have a computer. There is an app that they can download on their phone and that you can use on your phone as well. So just check out the chat for that. David or Daniel, if you can post some information on Oceans and how to sign up for Oceans, I think that would be appreciated, because there was actually some questions about that as well. So we are at time now, and I just want to thank our panelists again for the time that they've taken to share their journey with us today. So Dr. Arieg Badawi, Dr. Nadine Laraya, and Dr. Daniel Pepe, and our two guest panelists, Dr. Jennifer Young and David Kaplan, who've been fielding lots of great Q&A on the chat. And thank you to you for your interactive participation. A reminder that there's fantastic links and resources on the OCFP website, which you can see there, and that we also have posted the previous webinar and will be posting in a few days a recording of this webinar along with a curated a portion of some of the resources that people shared and some of the Q&A. This 1 hour is accredited, and you will be getting your certificates in the mail. You will be getting your certificates via email. I do want to ask you one favor, which is to fill out the evaluation that we're going to be emailing to you shortly. That really helps us to plan. In particular, we'd like to know what topics you want. Based on your feedback, we are going to be doing bi-weekly sessions. Thank you very much again for attending. Our next session will be 2 weeks from now. We hope you'll join us, and please do share what you learned today with your colleagues and invite them to join us again. Take care, and as everyone says, stay safe.